Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that you can download the PDF of today's ECG document down, linked in the description below, and follow along and make your own notes. And don't forget to like this video and subscribe to the channel if you enjoy this content. So let's jump into it. So the first thing I'm going to do, like always, is look at the forest, and the trees of the forest are my QRS complexes. And so if you look, I've got maybe pick lead 2 here, I've got a narrow complex rhythm. Seems to be pretty regular, and it stays regular throughout the entirety of the rhythm. My QRS is narrow, like we said. Now let's try to calculate the rate here. Maybe choose this one that lands on a solid line or so. I'm going to count the number of millimeters. So we've got 5, 10, 15, 20, 25, 30, maybe 35 millimeters. So 35 millimeters. And we know that we can calculate using this millimeter system, do 1500 divided by the number of millimeters in the R to R intervals. And so this is a rate of 42 beats per minute. So we have a bradycardia. And this is a narrow complex bradycardia, which makes me think that conduction through the ventricles is occurring through this His-Purkinje system that we have. And so as I think through that concept, I think, well, it's either a bradycardia that is arising from the junction, or it could be a sinus bradycardia. There could be a sinus rhythm and the AV node is blocked and only letting down a certain number of QRS complexes, right? That's just what I'm thinking through. And so what I do is I start to kind of evaluate for my atrial activity, right? What are my P waves doing? And so you can see my P waves here. I see some P waves. Those P waves, as I look through the rhythm, they seem to be upright in lead 1. They seem to be upright in AVF. So there are sinus P waves in the rhythm. Now what I noticed though is that some P waves, like this one, seem to be right in front of the QRS. This one kind of seems to be in front of the QRS as well, but what I'm seeing is when I look through other QRSs, I'm not really seeing atrial activity that appears to be kind of driving that rhythm. And so let's evaluate my AV node function. My AV node is going to be done by evaluating my PR interval. And so I want you to think, is it worth, is this PR interval right here, is that what's really driving this rhythm? Something that I want you to have seared into your brain is we've got a narrow complex bradycardia at 42 beats per minute, and it's regular. Okay, and we know that the AV junction, which sits right here, the AV junction is able to produce a narrow complex rhythm at 40 to 60 beats per minute. We call that a junctional escape. And junctional escape rhythms are regular, and they tick away at that rate. And so when you see something that's 42 beats per minute, you should think one or two things. If it's regular like this, you should think, is it junctional escape, or is it either one, severe sinus bradycardia, or is there a second degree AV block that conducts in a 2-to-1 fashion, or a 3-to-1? And I don't see that. What I notice is if I look here in lead 2 rhythm strip, I've got P waves that are just marching through the rhythm, right? So if we find the P waves, actually, we'll look at V1. Notice we've got P wave, P wave, P wave, that's just marching through at a very regular interval. There's a P wave kind of buried at the end of that QRS there. P, P. Remember, P waves are these sharp deflections, and so some people would even miss this P wave, but it's buried on the T. If you look at the next T wave, you see that doesn't occur there, and so you can compare T waves. So you have P waves that are marching through, and you also have QRS complexes that are marching through as well at a slower rate. And the P waves are not conducting to the QRS in any meaningful way, right? This P wave just happens to land in front of that QRS. So there's complete dissociation between the atria and the ventricles. And when you see that, especially in this regular, really narrow bradycardia, this is really characteristic of a complete or third degree AV block. And that happens when the AV node is completely blocked. And so you have P waves coming from the SA node, just marching through, right? And look at the P waves. They're occurring at an interval here. If you look at this one to this one, my atrial rhythm is occurring at a rate of 300, 150, 100, 75, probably 70 beats per minute. But my ventricular rate is occurring at 42 beats per minute. And that's because these P waves, like we said, are just depolarizing the atria, but they're being blocked by the AV node. And so the ventricles are like, well, I need to beat. So luckily, this person has an intact His bundle that can fire off junctional beats into the ventricles at this rate of 40 to 60 beats per minute and keep this person alive. And so now that we've established that, let's continue to evaluate our QRS complex. Our QRS is upright in lead 1, and it's narrow, and it's upright in AVF right here. So that tells me that my QRS axis is normal. It's down and to the left. That's good. And my R wave progression, you can see, I don't have much of an R wave here in kind of that septal region, but I do develop an R wave that appears to become dominant here a little bit late in V5, V6. My QT interval, you can see in between R to R's, my QT terminates at least by the midway point. That's reassuring. And when I look for pathological Q waves and ST or T wave changes, right, in the setting of a third degree AV block, we want to make sure that they're not having a right coronary artery STEMI or occlusion. And so I immediately go to my inferior leads that are supplied by the right coronary, and luckily I don't see any ST or T wave changes that are really concerning for an active myocardial infarction. Perhaps you can see some deep Q waves here, some Q waves. So maybe potentially an old MI in the inferior region. It's hard to say. Definitely some pathological Q waves here in the septum, right? We have deep Q waves. I don't see any positive deflection. Remember that a Q wave, by definition, the first deflection of the QRS must be negative to call it a Q wave. So a Q wave would be something that goes straight down, but if you have a little R wave before it, that would be an RS. Remember, deep Q waves have to be the first deflection. And so I would say we have septal Q waves here, pathological Q waves in the septum region. So that person probably has a previous septal MI. And so let's put this all together. We have a complete third degree AV block with AV dissociation with sinus node beats marching through. And we have evidence of potentially pathological Q waves in the inferior lead 3 only. But we have septal pathological Q waves that indicate that maybe this person had a previous septal MI, right? Age, we could say age indeterminate. And what that means is that it could have happened last week, could have happened last month, we don't know. And so, but we just know that the septum is unable to conduct tissue, or it doesn't have tissue it's able to conduct, right? And remember that V1, V2 represent septal depolarization, because we know that the septal depolarization is supplied by these little fibers that come off the left bundle. And so we should expect depolarization of the septum towards V1 and V2, and that gives us our little septal R waves. And so when you lose those septal R waves, like we do here, that's what you think. So I hope this helps you all. If you have any questions, throw them down into the comments, and if not, thank you so much for watching, and we will see you on the next ECG of the day. Take care.